You're listening to The Q Switch with your host, Spence.
Welcome one and all to the Q Switch Conversations podcast. I'm your host, Spence, and the mission of this show is to tackle subjects currently impacting ophthalmology, where we invite the innovators, thought leaders, and forward thinkers shaping the field of ophthalmology to discuss their unique perspectives. So let's jump right in. All right, everyone. Today, we're going to talk about the kind of surgery that makes most of us quietly say, I'm really glad someone else is doing that. My guest today on this episode of Fixing the Unfixable, the Next Frontier in Anterior Segment Surgery, is none other than Dr. Brandon Ayres, cornea and anterior segment surgeon and one of the shareholders of Ophthalmic Partners of Pennsylvania, which is located about 7 miles outside of the Philadelphia City Center. He also serves as the co-director of Cornea Fellowship at his alma mater, Wills Eye Hospital, as a longtime educator, researcher, international lecturer, and has the distinction of being the first at Wills to perform DMEC. But what really drew me to invite Dr. Ayres on the show is that the way he blends old school medicine, compassion, time with patients, and trust with cutting-edge surgical innovation, advanced technologies, and modern techniques. He's basically proof that you can be both high-tech and high-touch, even if it means coming in early, staying late, and refusing to cut corners. On the show, we'll be discussing what some may call a micro subspecialty, anterior segment reconstruction. Dr. Ayres, I'm super pumped to finally have you join the Q Switch. Welcome to the show.
Thanks, Spence. Thanks for having me. It'll be fun to be here.
So let's not waste any time. How about we get right to it? So let's go and start by setting the stage. When people hear anterior segment reconstruction, what's the simplest way you explain it, and how did the procedure develop over time leading to how you perform it today?
So anterior segment reconstruction is kind of a subset of itself, and you can get there all different ways. You don't have to be a cornea specialist. You can be glaucoma, you can be comprehensive, but basically it's taking a combination of surgeries. The way I describe it is doing surgeries that you probably don't think of as typical surgeries and then combining them into one procedure, hopefully to help a patient who thought that maybe their situation was initially hopeless or helpless.
Mm-hmm.
And we can get more into that, but it's basically fixing problems and trying to be creative in eye surgery to solve complicated problems.
Was there a specific patient complication, or is this can't be solved with one trick kind of a moment that pulled you deeper into complex reconstruction?
That's a really good question. And, you're supposed to be good at interviews and answering these questions. And I have no idea why I do what I do. I think it's partially hardwired. It wasn't like my grandma had some problem and I wanted to solve it, so then I went into ophthalmology. I'm here kind of by mistake. I 100% was going to be an orthopedic surgeon. I didn't go to medical school. I went to orthopedic school. And then by mistake, I walked into a room where somebody was doing retina surgery, and I thought it was like the coolest thing I've ever seen. So I quickly changed my mind and went into ophthalmology. And even though the retina surgeon convinced me to do ophthalmology, I ended up doing cornea and then going into anterior segment reconstruction. Now, this is going to sound as cliche as it gets, but I love fixing stuff. Like, I don't like easy, I like challenging. I like fixing things. Did you ever hear of something called Dorodango?
No, Dorodango.
I might be completely mispronouncing it, right? It is the art of taking dirt and polishing it like it's jewelry, right? So
interesting. This is a real thing. This is a real thing.
It's a real thing.
Okay.
And I'm not equating patients' eyes to dirt, right? It's not the same.
Let's make that clear.
Yeah, right. But taking something that other people think is basically a done deal, there's nothing we can do, it's not going to help, and trying to work and polish and change and be creative and take what somebody else said probably can't be done and then turning it into a work of hopefully seeing well art, I think is just amazing. It's challenging. It challenges my surgical skills. It makes me consider options that you usually wouldn't consider, creative surgical approaches, new techniques, instrumentation. It takes an army to fix this little tiny eye. So the Dorodango is taking that eye that people thought was a goner or a done deal, and trying to, with surgical skill, precision, creativity, the help of a lot of other people, the skill of a lot of people who I've built my skills upon, get that patient back to where they need to be. And hopefully on the way out, they feel like their life is better because they met me.
Well said. So because this really is a multi-skill surgery, when did you realize the winning formula was combining four major capabilities or skill sets? And correct me if I'm wrong here: anterior vitrectomy, IOL exchange, iris repair, and iris replacement, instead of treating them as separate problems.
Yeah, so these are cases where, people will often ask, how'd you learn what you do? Because we'll show videos, and I've got a YouTube channel. This is not a plug for my YouTube channel, but we take these cases, these big cases, and we try to do that Dora Dangle, right? Take that eye that looks like it's helpless, never going to look an eye again, and suddenly it's back to normal. But that comes from, those complicated surgeries come from simple steps that you then put together. It's like a dance, right? You don't learn the whole thing at once. You learn it in small bits, and then you put it together to become a well-orchestrated surgical procedure. So when patients have some of these bigger anterior segment problems, you're often dealing with vitreous. You're dealing with implants that are out of position or dislocated. They often come with iris damage. So you'll have to fix an iris or potentially replace it. And then as a cornea specialist, the cap on top is probably corneal surgery, because the cornea is basically a wear organ in the eye. And the more surgery you have, the more damage the endothelial cells can get. And sometimes after fixing everything else, you have to repair the cornea. So I think I would probably include cornea repair in that skill set. But not necessarily. I'd say it's an optional thing for anterior segment reconstruction. And there's lots of great anterior segment specialists who are not cornea specialists. Maybe they're glaucoma specialists or something else. But yeah, but the mixture of that skill set is what allows you to not be afraid, right? To have the kind of the skill and the knowledge and the experience to tackle bigger problems, and not make it feel like you're like, oh my God, oh my God, oh my God, the whole time. You're like, hey, I can take care of this. If I just go through A, B, C, and D, we're going to get this surgical procedure done.
Now, with the four different skill sets, is it kind of like tools in your tool belt, and you may use one or two of them, or each procedure does include all four kind of building on each other in succession?
Yeah, no, you're 100% right. It is, sometimes one skill set, sometimes two, sometimes all of them.
Okay.
But when somebody is trying to learn, it's much easier to learn each of those skill sets independently. Start simple, right? And I think one of the most important, this is just my take on this, is being comfortable with anterior vitrectomy. Or you can also do a big push right now is for anterior segment surgeons to use the pars plana. So a pars plana approach anterior vitrectomy. So you're now breaking some of the rules. As an anterior segment surgeon, vitreous is the enemy. We don't want to see it. We don't want to deal with it. But to get people back to where they need, you've got to be able to skillfully deal with vitreous and realize that a vitrectomy is not an admission of guilt. It's a necessary step to some of the surgery. So I think step one in learning how to kind of take care of the entire anterior segment is just becoming comfortable and good at doing an anterior vitrectomy.
So let's talk patient needs. What are the most common conditions that bring someone to you for this kind of reconstruction? Is it trauma, surgical complications, congenital issues, severe iris defects, glare, photophobia? What shows up the most?
They all come to us, right?
Okay.
Everything. And if I'm going to break it down, one of the things that we see almost every day is dislocated IOLs or complications from cataract surgery or IOL implantation. But that often comes with iris damage and vitreous prolapse. I'll give you an example that we see almost on a daily basis: floppy iris syndrome. So a surgeon is taking care of a patient. Maybe that patient has used Flomax, right? We all know that Flomax potentially gives floppy iris. Got into surgery, that iris got a little out of control. It's a very uncomfortable situation when the iris just will not stay put. Then the cataract surgery gets more complicated because maybe the view is reduced. There's a capsular complication. Try to put in a sulcus lens and it's just not sitting correctly. And the mission of the surgeon in sitting in that seat, and I do not like to play armchair quarterback with this stuff. You know, when you are doing surgery and there's a problem, you do the best you can for your patient. I can't stand it when people say, well, what I would have done is this. You can give tips, but when you're in that seat and things are going sideways, your mission is take care of the patient, take care of the eye, get out of town, keep things safe. And then that patient may get sent over to us or to me to try and take care of or do a revision. So we may have an implant that's not quite centered, or maybe it's slightly dislocated. There may be a capsular complication, so we have some vitreous prolapse. And you can bet with floppy iris, you'll have an iris defect. So now we're going to have to do the duodengal, right? We're going to have to try to take that scenario where the patient is nervous. The referring doctor may be nervous. Oh my gosh, what happened? What am I going to do with this patient? We want to get this fixed up. Patient certainly wants to see. And we're going to try and break that problem down into its components and take care of each component. Vitrectomy for the vitreous prolapse. Look at the IOL, get an implant in that's going to be secure. Maybe that's sutured in place. Maybe it's a sulcus lens. Maybe we can use the capsular bag. And then once that's situated, now can we also fix the iris so that the patient doesn't suffer from glare after surgery from a large iris defect? So when you look at these eyes and they're very, that has a very complicated look, break it down into its components, use your surgical skill, and then systematically come up with a plan to get the patient better. Trauma is a big one also. Congenital defects, we see a lot of congenital anterioritics, congenital colobomas, which can be very challenging to repair. But one of my favorites is just simply a surgical complication, patient's nervous, referring doctor's nervous, and we're trying to get everybody fixed. Two patients in that scenario, right? The patient in front of you in the chair and that other doctor who called you said, hey, I had an issue in the OR today. Can you help my patient? And we're not only trying to help the patient, we're trying to help the doctor know that his patient will do well and we'll take good care of him.
Of course. So when you're evaluating a case, what makes you say, this is a great candidate versus this is high risk and we need to rethink the plan?
Well, I think that goes into your thought process with all of them. And it'll depend on your comfort level. I am spoiled as can be, right? Every day we'll see patients who come from the Philadelphia area and well beyond. And we get to do surgeries and use techniques that most surgeons will only do once or twice a year. So the more comfortable you get in that setting, the more you feel comfortable tackling. But there are plenty of times when somebody was sent to me to say, hey, can you do this or do that? And after we take a look, we say, you know what? I think we're going to change the plan. Maybe we need to enlist the help of a retina surgeon or a glaucoma surgeon. Or although I know you were sent here for a lens exchange, I don't really think that's in your best interest. Maybe we need to try something else. So, knowing, and here's the advantage of just experience. I would never tell anybody that I'm a better surgeon than somebody else. I don't think that's true. But we do have more experience in some of these complicated scenarios. And so we've seen what happens when we do this and what happens down the road. And so we do sometimes switch the plan. A patient says, I'm here for this. And you go, I don't think that's really what you need. I think what we should do is this. And then telling the patient why we think that, giving some examples. So we don't make it seem like the referring doctor didn't know what they were talking about or that I don't know what I'm talking about. So you always have to have that out of the box, thinking out of the box and open mindset to take care of these patients. If you get pigeonholed into one way of doing things or one way of thinking about it, you're going to miss some opportunities.
Mm-hmm. Sounds like being flexible and willing to pivot and kind of just, what do they call it, the audible in football. Where game time decision and, you got to change the plan. And what we initially thought going in, now we've taken a look and we have to do something different. And I think what's more important, I think you're really good at this, is being able to communicate that to not only the patient, because they're kind of like, what? What's about to happen now? And then you said that cascades over to the referring doctor as well. So everyone's on the same page, which is a very delicate balancing act to make sure that all these pieces are working together and are on the same wavelength.
It's really hard. And I love the sports scenarios and the sports, using that with patients. And I say it all the time. We're going to call an audible, right? Or they say, well, what are you going to do? And I'm like, you know what? I don't know. I really don't, but I'm going to have 5 different plans in place. And depending on what happens, we're going to do plan A, B, C, or D, or maybe some of plan A, and then shift to plan B. Because it really depends on what we see in the operating room. So having the The confidence, the skill set, and the experience to have that flexibility is really what helps. And there's plenty of times. In fact, I'd say, over half the time, we have to change our plan midstream, mid-case. As long as the goal is to get that patient safely repaired and seeing well, if your eyes are on that goal, everything you do should point towards that goal. And that way, at the end of that case, no matter what twist or turn you had to take, it's all about getting the patient better.
So I'd like to take a moment to maybe break down those four skill sets, and we'll call them pillars. So the first pillar being anterior vitrectomy. Why is vitreous management such a make or break step in these eyes, and what are your personal non-negotiables for doing it safely and efficiently? I saw once that you discussed small gauge, high-speed vitrectomy workflow in this setting.
Yeah, vitreous is the enemy in the anterior chamber, right? When we're trying to do, whether it's iris repair or lens exchange or lens replacement, you name it, if there's vitreous in the AC, you've got to safely remove it. Otherwise, you're putting traction on the retina. The patient's going to have retinal tears, retinal detachments. No matter how beautiful you make the anterior segment, if there's a retinal detachment, the patient may not do well. So I do think that the first pillar of reconstruction is being comfortable with vitrectomy. I do often use a pars plana approach. You do not have to. But when we're going to be, say, suturing a lens implant, we're already going to be making incisions in the pars plana to put the implant in place. So you might as well use those incisions to clear the vitreous.
Makes total sense.
Being comfortable with vitreous removal, I think, is critical.
So the second pillar, IOL exchange. In these complex eyes, what usually drives the decision to exchange the lens? Is it decentration, wrong IOL, instability, glare issues, trauma history? What are you trying to achieve optically?
So most of the time, or many times anyway, what we're dealing with is a lens that's already dislodged or dislocated. Sometimes it's because maybe the patient had pseudoexfoliation or trauma, but for some reason that implant is nowhere close to where it belongs. And so it's an easy decision that we're going to have to take that lens out and put a new implant in. There's only a certain number of implants that can be either suture fixated or haptic fixated. And so if the implant that's in the eye either wasn't correct or can't be adapted to fixation, it's got to go. So the exchange is often a relatively easy decision when you've got severe subluxation, or what we call subluxation in the bag. And that is going to probably require vitrectomy, some kind of secondary IOL technique relying on either suture fixation or haptic fixation. So alternative ways of holding a lens in place. And there you're just trying to get a lens centered in the eye with a prescription that's going to help that patient. So relying on good biometry and good technique is critical in those cases. Now, there's other lens exchanges, right? Another, and I know you were about to say something, but another scenario could be that somebody comes in and they're not happy with their lens implant. Okay. Or maybe they had a cataract surgery and now they've had a YAG capsulotomy. And now they decide, you know what, this lens is giving me too much glare or halo, or for whatever reason, I don't like the prescription. I need to get this lens out. Now we have a lens exchange, and there's a lot more options there, because that implant is in good position. Do you fix the problem with laser vision correction, or do we have to take the lens out and put a new implant in? What kind of implant will it be? Where are we going to place it? Is it going to be in the bag, in the sulcus? Is it going to be captured in the anterior capsulorhexis? And the refractive goals, was it a toric lens? Is it a non-toric? Do you need a toric? How are we going to deal with these? So that all goes into the thought process. And if that posterior capsule is open and the lens has to come out, we're going to have to do a vitrectomy to get the vitreous out to safely do the lens exchange. So again, the first pillar, second pillar, go together to do a safe surgery.
Yep. Now to that third pillar, iris repair. Before we even talk about replacement, where does sutured iris repair or pupilloplasty still shine, and where are the scenarios where repair just can't get the patient where they need to go?
Yeah, multi-step question there. I mean, iris repair is probably my favorite thing to do. And the reason is it just relies on creativity. There is no step A, B, C with iris repair. You literally get into the operating room and we start with micro instruments. We start pulling on the iris to see where is it stretchy, where is it not stretchy? Can I get this to reach over here? And then using probably 3 or 4 different suture techniques, we start to try to piece the iris together. It is pure creativity. And that's what I love about it. And the people look at the eye and the iris. When you talk to somebody, you look them in the eye. And when somebody has an iris defect, the question's always going to be like, what happened to your eye, man? Like, what's going on there? They might not want to say it, but that's going on in their mind. And even though patients may say, you know what, I had this trauma when I was 4 years old, I've just been this way. It doesn't bother me anymore. You don't have to worry about fixing it. Deep inside, they probably do care. When we're trying to take care of the entire patient, right? I think like our what we do is so important. It's so big. We're doing these big surgeries. It's a little teeny eyeball, right? And so we do cataract surgery every day. We do transplants every day. We help patients every day, which is a great thing in ophthalmology. But it's not every day that I think that I completely change the way patients feel about themselves, right? I may make them see better and they're happy, but it doesn't change maybe their outlook on life or their feeling of self-worth. When you do an iris repair and you take somebody who looked somewhat disfigured in a microscopic way and you repair it, I've seen patients go like I've not even recognized them in the waiting area because they changed the way they carry themselves. I've seen patients go from depressed and shy and kind of anxious about their self-appearance to being very confident and looking completely different.
Wow. Is that
And
right?
to me, that means more than anything because not only did I help somebody see better, but I completely changed their outlook on life and how they see themselves and their level of confidence, right? And I think that's what we're here to do. And I think that's why I love doing what I do because I like to see that transformation. And it doesn't work in everybody. We can't fix everybody, but we try in everybody because we're going to get a couple success stories every year where we've made a huge difference. So I love iris repair. I think it is one of the most creative and challenging things that we do. And although it might not make patients see that much better, it reduces glare, but it changes the way they see themselves.
And I think there's value there. I mean, when they look themselves in the morning, because the only person you have to live with all your life is you. So when you get up in the morning to brush your teeth or what have you, and you want to be able to appreciate what you see because that's the way the world's going to see you as well. So I think that there's a lot of value there. And I think having a good attitude and self-worth is important, just how you carry yourself and how you interact with the world. Absolutely. So I think that's a good thing.
That's a great thing.
So that last pillar, iris replacement, when repair isn't enough, how do you decide it's time to insert a prosthetic iris? And what symptoms are you most often trying to eliminate? Is it glare, photophobia, dysphotopsias, or maybe a cosmetic concern? So
the primary thing we're trying to get rid of with iris prosthesis is glare. That's what the prosthesis is approved for. That's what we did in the FDA study. And when I'm talking to patients about iris prosthesis, I'm talking about glare. Now, a big component is the cosmetic component. Just like iris repair, patients don't like looking asymmetric. They don't like that they've got one giant pupil, or maybe they don't even have an iris, or maybe they have aniridia. They were born without irises entirely. They've had these kind of sort of black eyes all their lives because they don't have any pigment in the iris or iris at all. We see it also with trauma, car accidents, bungee cords. I mean, you name it. Blunt trauma is a big problem. And it just basically gives you so much iris damage that there's nothing to fix. If we don't have iris to repair, what are you going to do? And until I think about 2016, we really didn't have an approved iris prosthesis. I was fortunate enough to be part of the FDA study that got the custom flex iris approved in the United States. So now we do have an iris prosthesis that we can use. There's still some challenges with insurance billing and things like that, but at least we have an option that we didn't have before. So in those patients where we used to say, you know what, we really don't have an option here except maybe a contact lens. You can put a contact on that kind of looks like an iris and maybe we can make it match the other eye. Now we actually have an implant that we can use. And that implant is color matched to the best of our ability to the unaffected eye. And what's pretty cool, if both eyes are affected, you can sort of choose any color you want. We've had some people use their brothers or mothers or family's eyes, or just go online and pick somebody famous. I had a patient who was like, I don't know, Brad Pitt's pretty cool. I wouldn't mind having eyes his color. Found a picture of Brad Pitt with his eyes, and that's what we use. But you can't have skull and crossbones. You can't do purple. It's got to look like a normal iris. So the cosmesis of it is secondary, but it is important. But the primary thing that we're doing is trying to reduce glare. And I do try and stress that because sometimes the color match isn't perfect. But from our distance, most patients look pretty darn good.
So now connect the dots for us. Why do these four components work better together as a single reconstruction surgery? And what's the synergistic effect that makes the whole greater than the sum of its parts?
Well, I got to say, Spence, sometimes you may be better off doing them separately. I mean, there are times when you say, I'm not sure that the eye can handle all this at once. Maybe we do this time, and then in a couple of months we come back and we fix that component. But most patients don't want to go to the operating room 2 or 3 times. And so when I'm talking to a patient about these larger surgeries, we're going to do a vitrectomy and then a sutured lens, and maybe put an iris prosthesis in, and maybe even top that off with a cornea surgery, I tell them all that if things are going smoothly, we can get this done in one surgery. It's one trip to the operating room, get you fixed. There's going to be some recovery involved, but hopefully just one surgery. However, if I think that things are not going our way, or you're safer by breaking them into separate components, I will fix as much as I can, and we'll come back and live to fight another day. In the end, it's about you seeing well and recovering, not about trying to get everything done all at once. But if we can combine them, I think it's an advantage. It's less trips to the operating room. Some of these patients are traveling quite a long way to get these surgeries done. That really shouldn't be an issue. Like, I don't care if you came in from Arizona. My mission is to get you seeing better. But it does come into play. Like, how many times do you want to fly back and forth? Or can you fly back? If you put an air bubble in the eye, you're not getting in a plane for a couple of days, right? So you got to take those into consideration. But I do like to try and get as much done in one surgery as possible. And I think patients appreciate that. Sometimes the biggest risk to go into the operating room is the anesthesia. And so if we can minimize return trips, probably better overall for patients.
What do you consider good outcomes? What do they look like to you in your hands? Vision, glare reduction, pupil function, patient confidence, and what does the literature say about functional improvement after our artificial iris and IOL reconstruction?
So there's a lot of data out there looking at lens exchanges and the safety of things like sutured lenses, and all of them will say that it's about the same as doing an anterior chamber lens, right? So there's a little battle going on out there with, what's best for patients. Do you need to suture a lens and do these special fixation techniques, or can I just put an ACIOL in? But in a lot of the patients I have, they have iris damage, or they don't even have an iris. So you don't have the option of an anterior chamber lens. So most of the studies will show that they're about equivalent when it comes to vision and complications. But with what we're doing, an anterior chamber lens really isn't an option. So we're layering this, one skill on top of the other, vitrectomy for the lens, then we do the iris repair, or we do the iris replacement. As far as the FDA goes for the artificial iris, right, what our primary endpoint was reduction in glare, right? And that's what it showed. Patients had reduced glare after the prosthesis. That's why we do it. It's not the cosmetic component. But do patients feel better about themselves when their iris is repaired or replaced? They absolutely do. And then the third part of that question is, what is success? What is good? Man, good for me, there's such a range because we're taking care of eyes that are not healthy. So some of them don't have the potential for perfect vision. So success for me is just somebody when they leave that says, you know what, thanks for doing what you did. My life is better. My vision is better. Maybe it's not 20/20, but they're 20 happy. And I get these messages sometimes that I get them at Thanksgiving and Christmas where, one of my patients, and a lot of them have my cell phone number, which I don't always recommend, but they get my cell phone sometimes. But I get these messages that say, hey, it's been 5 years. I thought that it was hopeless. I was blind. We came out to see you. I can see my kids. Here's my family photo from the holidays, and it's a normal looking person in there with no big red eye from an iris defect. And to me, that's success because it did what I want to do, where someone came to see me. I probably just fixed their eye, but I made their life better. Right. So that's success in my hands. It's not 20/20, but do I love it when they're 20/20 also? I do. I absolutely do.
Added bonus. So on the flip side, what are the most common complications or points of failure you watch for? IOP issues, inflammation, endothelial risk, suture problems, lens instability, and how do you proactively reduce those risks?
So there is a lot of risk with these surgeries, and there's risk to the patient and there's risk to the surgeon. We're sometimes managing complications from another surgeon. So we're handed a problem. We have to safely navigate through those waters. And so it's long discussions with patients with this kind of a surgery. You have a risk for infection. further complications, inflammation, retinal tear, retinal detachment, but we're going to do our best to monitor you for those to minimize that risk. And truth be told, most of these patients do very well, and the risk is relatively low. But you've really got to be honest with your patients and say, look, there is some risk to this. I think it's worth the risk, but you got to know what you're getting into. This is not just a 5-minute or 10-minute surgery. This is a long procedure with a longer recovery. And we do see issues with sutures, suture erosion. You can see, iris chafing on the lens implant if it's too anterior. We can see repeat dislocations. I mean, you name it, you can see it. But similar to learning the techniques, you also learn what to look for and how to not leave your patients in danger. Doing peripheral iridotomies to reduce reverse optic capture or kind of reverse pupillary block, which can give a UGH type syndrome where patients they get chafing of the iris on the lens implant, pigment goes everywhere, pressure goes up, you can get bleeding, and then it's, okay, back to the OR, we got to fix that. Endothelial failure is something that I bring up with almost all the patients.
Really?
These are
Okay.
patients we get cell counts on. So we can actually look at the cornea and look at the health of the cells. Because a lot of these patients have been frustrated. I had surgery here and then this happened. Now I had surgery over there and then that happened. So they're like, what's next, doc? Like, what's the next thing to fall apart? So I like to show them their cell count to say, hey, look, you've had 6 surgeries and your cornea cells are running low. And I often just I talk to patients like their cells are brakes. Like the more you hit the brakes, the more the brake pads wear out. You got to replace them once in a while. You've had 6 surgeries. Those corneal cells are getting worn out and they don't replace themselves. So if we go in and do this big surgery, there's a very real chance in a couple of years we're going to have to fix that cornea. I don't want that to be a surprise, and I don't want you to be disappointed. We can fix it. Like we can fix that and keep you going. Maybe it happens in a year, maybe it happens in 10, maybe it never happens, but you got to know that this is going on and we're going to watch it. And if it gives you a problem, we can fix it. That's why I like the cornea aspect of it, because that is usually one of the last things that fails on a patient. Hopefully it's the last thing that fails. We can get that fixed. And then they know that we can handle that as well. They already know the surgeon, get the cornea fixed, and then get them happy for the rest of their lives, hopefully.
Bring it to the patient experience. How do you counsel someone throughout this journey from initial consult to recovery? What they'll feel in week 1, what improves gradually, and what timeline do you give for this so that this close to new normal is their reality?
Yeah, so the first thing you have to understand when a lot of these patients come into the office is they already know they've got a big problem, and they may feel a bit hopeless about that, and they're nervous. They're meeting another doctor, another surgeon. They're frustrated. They may have been bounced around, and so we deal with that first. Hey, look, we can take care of this, and I think as we go through the workup, and we get a lot of testing, and they'll see, they'll see a technician or two. They'll probably see a fellow. They may see an optometrist. Then finally, I walk in, and we kind of do the final assessment. And my mission when I talk to those patients is to just speak with confidence. Like, we've seen this before. There's very few things we haven't seen, but they do come in. I'm like, geez, this is new. I haven't seen this before. But I don't say that. I think it. I don't say it. Well, just like, man, what happened to you? But anyway, just, talking through each of those problems. So we have this, and we have that. So we have an example. We've got vitreous prolapse. You've got a lens implant that's dislodged, and I see a large iris defect, right? That's a very common scenario. We need to do this to get rid of the gel. We can help get the lens implant back in place or replace it. And then at the end, we can fix the iris. And speaking with confidence so they know that there is a pathway to success here, right? And they'll say, well, how many times have you done it? And I've got a scrub hat on today. I was in the OR this morning. I'm like, I just did it. Like, we just did this a minute ago. We do this every week. This isn't like it's like seeing Bigfoot. It may happen once in every 10 years. Like, this is something that we fix, and we've got experience with it. I also tell them it's big surgery. This isn't a little polishing of the eye. We've got some incisions to make, and it's going to take you a while to get better. Where are you from? Do you have a place to stay? Can you get back in a plane in a couple days? It's going to take you, and it depends on what it is, Spence. Some of these things we can get better in just a couple of weeks, but some of them can take 2 or 3 months, or if you have to do a transplant, it could be a year before they're technically healed. So giving them a realistic look at what that calendar looks like, how many times they're going to have to come back, will they be able to travel, and we give them a little bit of the unknown. We usually see a day after surgery, a week after surgery, a month after surgery, 3 months, 6 months, 12 months. But if something's going on, I'm going to see you every day or every week until that problem is resolved. And you can have problems with these cases. So I try to be very realistic with patients, and I give them a lot of time in the lane so they understand what they're up against. But I also want them to know that we're here to advocate for them and to try our best to get them through it. They're not going through it alone. We're there with them.
Mm-hmm. So let's talk gear. And I'm talking a real like surgeon type of conversation. What instruments, devices, and technology are essential to making this operation predictable? Specific vitrectomy approaches, iris prosthesis selection, fixation strategies, and what have you changed over time as the tech has evolved?
Man, I've got stuff. I love gadgets, and you need gadgets. You know, I actually carry my own instrument set, and sometime I'll tell you a story about how I dropped my instruments on the highway and I got hit by a car, but that's a different podcast probably. I have got my own set of instruments that I take with me from OR to OR so that if they don't have what I need, I know I've got it with me. But you do need extra instrumentation for these cases. This is not a, I just need a phaco and a second instrument, kind of surgery. You need anterior segment instruments, micro instruments, graspers, iris graspers. You're probably gonna need some kind of capsule retractor. You gotta be comfortable with capsular tension rings. You've got to be comfortable with suture fixation techniques and what kind of suture are you going to use? Is it going to be Prolene? Is it going to be name brand Gore-Tex or polytetrafluoroethylene? You've got to probably know what polytetrafluoroethylene is, right? If you're going to do these cases. There's a lot of lingo and a lot of instrumentation. And it's using that instrumentation. I mean, we rely on that. I can comfortably say that I've helped build my career because I had the instrumentation to do it. In fact, I've even seen patients referred in that says, well, Brandon's got the tool. Like I've seen it on a video. Like he's got it. Go see him. He's got the tool to get this fixed. So you got to be a bit of a gadget person if you want to get these cases done. And you've got to be willing to be surgically flexible. If they don't have an instrument, well, what are you going to use in its, in its stead, in its replacement? Mm-hmm. So I think having the surgical flexibility is important. But you've got to have instruments, you've got to have suture, and you've got to have the know-how. So, yeah, very technical. Lasers are helpful. We use a femtosecond laser for many cases, but not every. Capsule retractors, capsular tension rings, micro forceps, anterior segment scissors for both the iris and implants. You got to be able to use a variety of different insertion cartridges. Sometimes we use a IOL inserter for the artificial iris. Sometimes we fold it. So you have to have forceps for folding. You've got to have an IOL inserter for placing it through a small incision. I mean, there's so much that you need. And I think when I first am working with a new fellow, it's interesting because they have no idea what the instruments are, right? So I'll come back and I'll read their note and I'm like, oh man, like they are so wrong. They'll write, they'll have the problem nailed down, but then they'll say, we'll follow, or we're just going to take a look at this and I'll see you in 6 months. I'm like, no. We're going to get this fixed. Like, you're not here for me to follow this. You're here for us to get this fixed. And we have the instruments to do it. And then as the year goes and the fellows see more and more techniques, I see that natural transition from this isn't just a problem. This is a problem that we've got solutions for, and we're going to offer those to patients and see if they want to get this fixed because they see what we have in the OR and how we tackle these problems, right? So I think having a mentor in this kind of a specialty is really important because you don't know what you can do until you've seen someone do it.
Well said, and I think leads into this this next question. So, like big picture, do you think anterior segment reconstruction becomes its own micro subspecialty, maybe even a formal fellowship track? And if so, what would a graduate need to be competent in? And practically, how is this taught today? And are there any informal credentialing expectations? And what do coverage and reimbursement authorization dynamics look like in the real world for these complex reconstructions?
Yeah, man, there's a lot of good questions in there, Spence. I've learned to do what I do mostly without fellowship training. I did my fellowship in bread and butter cornea, and since I've done my fellowship, which is now just a little under 20 years ago, everything has changed. And so I think you have to be a lifelong learner and willing to teach yourself or find courses so that you can keep learning and keep changing. Most of the surgery I do today, I did not learn in residency or fellowship. Now, having said that, if you can find a fellowship that has a very active anterior segment surgeon, it really speeds up the process of learning, because you're going to be able to see and do and watch an experienced surgeon, and it's going to shorten that pathway from, in learning. And even now there are fellowships that are considered anterior segment, where you can see and learn and do these techniques. And I think there's a strong advantage to that. Now, when it comes to reimbursement, these are bigger, longer cases, right? So cataract surgery runs the world of the anterior segment surgeon, right? That's our bread and butter. That's what we do. Doing lens exchanges, sutured lenses, iris replacements, iris repairs. You spend more time in the operating room. You do less cases per day, and you've got to find a way to get efficient at those cases. They do reimburse well. Like we combine a lens exchange, a vitrectomy, and iris repair, iris replacement. That reimburses pretty well, but not if it takes you 4 hours to do. Like, you're much better off doing a whole bunch of cataracts that day, or a bunch of vitrectomies or tube shunts or whatever else you're doing. But once you get good at these surgeries and you know what you're going to do, you can get through them pretty efficiently. And then, I've built my career on doing these bigger cases. I still do simple surgeries too. They're not all these massive cases, but they fit into the day. We get them done. And in the end, I can still feed my kids, dinner at night, and I go home feeling like I help people.
Nice. So as we wrap things up, if you could fast forward, what does anterior segment reconstruction surgery look like in the years ahead? And what's the next frontier? Better fixation, better materials, more standardized training, improved outcomes data, or broader access?
So I think it's a combination of things. We already know that we have some improved materials coming. But right now, we often are sort of repurposing what we have to make it work. We're taking what we have and we're sort of adapting everything. And we already have some newer materials that are on the way that I think are going to help the anterior segment surgeon. But technology, materials, and instrumentation is really what helps. That, and I think training. I think we're going to accelerate the ability of surgeons to go from little experience to a lot of experience, and that helps patients. That, combined with technology, better instrumentation, and new materials, I think is going to be where we're at. So I think in 10 years, we are going to have better techniques, better materials, and maybe some purpose-made devices for the anterior segment surgeon for patients who right now really don't have an implant or a device made for that problem. So I think we'll have more purpose-driven devices and implants that we can use in patients with bigger problems. At least I sure hope so, because they can use the help.
Side question. I think in our earlier conversation, we were preparing for the show, you're saying that not a whole lot of people actually do this, by definition, the anterior segment reconstruction. Is you and a small handful of other folks. Is the demand far outweigh, what you guys can actually complete in terms of helping patients with these different conditions?
Yeah, we're pretty busy, right? So if you are a young surgeon, you're listening to a podcast, and anterior segment reconstruction seems like something that's pretty interesting. Complex cases are interesting. There is room everywhere for that surgeon who welcomes other people's problems. Our backlog for surgery is several months. It's hard to get into the office. So there's room for growth, and there's room for more in this field. And it's just looking for the surgeons who say, you know what, I'm going to take the time and invest in these techniques. They're very interesting. But the downside is that sometimes you see the light, you're like, man, there's an easier way to spend the day in the OR. But I don't think that there's a more interesting way to spend the day in the OR. So yeah, we need some help. We could use some more surgeons who take a real interest. There's plenty of pathology out there. Lots of patients need help.
So Dr. Ayres, this was absolutely phenomenal. So thank you for walking us through a procedure that's equal parts surgical precision and problem-solving artistry. You didn't just describe what anterior segment reconstruction is, you made it clear why it matters. Restoring function, comfort, confidence, and quality of life in patients who often feel like they've really run out of options. But before we go, if people wanted to learn more, refer a complex case, or follow your work, what's the best way to reach you? And feel free to share your preferred email and where they can most find you active on social media or your YouTube channel.
Sure. Yeah, so my YouTube channel is probably my most active kind of media channel, where I try to put interesting cases up there and show techniques. It's meant to teach surgeons, not patients. And that's just YouTube, and my handle is just Brandon Ayres. And then my email is pretty easy. It's just my name, Brandon Ayres. And Ayres is Ayres. It's often misspelled, at me.com. So Brandon Ayres at me.com. Reach out to me, and I'm happy to get back to you.
So if today's conversation resonated with you, whether it's refining your approach to complex anterior segment cases, expanding your surgical skill set to include vitrectomy, IOL exchange, and iris reconstruction, investing in instruments and technology that make high-level reconstruction possible, or simply rethinking how you restore both function and confidence in patients who thought they were out of options, reach out to Dr. Ayres and keep the conversation going. To my dedicated audience, as always, the Q-Switch Conversations podcast is my way of giving back to an eye care industry and community that's shaped my career, my perspective, and my passion for what we do. This platform is truly built for you, the clinicians, the innovators, and change makers redefining what's possible in our field. So if you have a fresh perspective, a unique experience, or know someone doing great things in eye care, I'd love to feature them on this show. You can hit me up on LinkedIn or drop me a line at d.spence@meridian.ch. And as always, we'd like to thank Riverside.fm and Passionate Media for making this show happen, and Meridian Medical for making it all possible. That's a wrap for this episode of the Q-Switch Conversations podcast. I'm Spence, and I'm out.
You're listening to The Q Switch with your host, Spence.